this is an interesting case of lateralized tympanic membrane following previous surgeries which were performed by our surgeons, and I tried to use a specific technique of total flap removal, as I showed that before with several videos. You can see we have a blunting and lateralized tympanic membrane, so I will remove probably part of his skin. This is a right ear, so this is 12 o'clock, 3 o'clock, 6 and 9. I will of course do this complete incision all around the canal, but first I will see with a needle if I can find any possibility to deal with this blunting. So I use this instrument to do that, trying to decrease the thickness of this, to see if I can increase the surface of the tympanic membrane by doing this. It's really thick. And of course, if I make a perforation, I don't mind at all, because I have to remove the whole flap and do a tympanic membrane grafting. I was using, I already took the perichondrium from both sides of the tragus. Really thick and hard, like a lot of fibrosis. Ciseaux. Table en avant, s'il vous plaît. Stop. So I'm at the level of the anterior wall here, and I'm dissecting this angle, this anterior angle. Ciseaux. So you can see now I'm enlarging the surface of the tympanic membrane. I have this exostosis which I will need to drill out. Canne mange du marteau encore. Canne mange du marteau. Encore, Canne mange du marteau encore. Bonjour. Okay, you see here the limit of the drum here. Passe, s'il vous plaît. Okay, so now what I will do the incision all around. So you can see this incision all around the ear canal. Alright, I'm going to dissect now the anterior wall, trying to elevate the anterior part of the flap. Passe. Décolleur. Passe. Okay, décolleur. All right, trying to continue the elevation of the flap. And of course, we'll have to check the ossicular chain at the same time because we have a really large airborne gap. It's 80 dB hearing loss in terms of air conduction with a 50 dB bone conduction threshold. Oh, you can see the big exostosis here, which I will need to drill out if I want to have a clear control of the exposure of the anterior angle. Alors, une lame de Silastic, s'il vous plaît. Le canet, mangez marteau d'abord. Okay, allons-y. All right, so now I will drill out the bone here. And as usual, you can see I'm using a diamond dust burr. I don't like to use a cutting burr. Takes more time, but I think it is safer, especially for the TM joint. Les ciseaux à frapper.
Les ciseaux à frapper. Les ciseaux à frapper. Dans la réserve, hein. Les pochettes élevées là.
C'est bouché là. Okay, so what I'm trying to do here is to make a kind of groove, and then I will use the chisels to finish the job. All right, so allez-y. Okay, that's fine. You can see it helps me a lot to do that. If I remove now as a whole the plaque, yeah, it's very nice. And now I can drill out the residual bone here, la fraise encore. Okay. The color. So I will continue now to elevate the anterior flap. Of course, we need to drill out a little bit more the bone here, because I cannot control the anterior angle, which will be very important here to try to avoid recurrence of lateralization following the graft placement. Table en avant, s'il vous plaît. Stop. So I put again the Silastic sheet, la fraise. Because of course I will want to place the graft over the bony canal wall anteriorly to cover the bone. Which is a very strong bone in fact. Oh, then to put in this. Okay, so I need now to drill out the inferior part of the anterior wall because I think we have some exostosis, residual exostosis on the right. You can see here. Décolleur d'abord, s'il vous plaît. L'aspi, s'il vous plaît. Merci. Allez, la fraise. Okay, now it looks fine. I think I can control the anterior angle. Décolleur. Yeah, definitely it's fine. I remove now the Silastic, and now I will open up the middle ear cleft. Calme. So this is between 3 o'clock and 6 o'clock. Okay. La lame de Silastic encore s'il vous plaît. I don't have a complete control of this anterior superior angle now. So maybe I have to do that a little bit more. I check that. La fraise. Really strong bone, really hard. Okay. Decolor. I think it's fine now. I can have access to the anterior angle, superior angle. You can see the nice exposure here, so it's good. La fraise encore, maybe a little bit more. Okay, that's fine. Now it's perfect. So I remove now the Silastic sheet, and I will continue the opening of the mucosa to join the inferior one. Alors, calmez. Ciseaux. All right. So now what I will do, I will reposition the flap anteriorly and go back to the posterior part of the flap. You can see this really bad graft that we have. You can understand the concept of this lateralization, which is completely adherent. Bon, alors donnez-moi les ciseaux bientôt. petit Tympanoplasty, s'il vous plaît. So what I try to do, I try to elevate this, to separate the anterior wall from what I would suspect is the previous graft or tympanic membrane. Ciseaux. Okay, we'll continue step by step. There we go. You can see now the tympanic membrane here, which is fine. So I need to dissect now the superior part of the flap. Calmez mon marteau encore. It's pretty thick here again. Ciseaux. This part, of course, I will remove it and reposition it at the end. Okay, you see now the flap is there. This is the skin, this is the previous graft. Oh, I want to separate them. That's it. Okay. All right, so la pince, s'il vous plaît. Non, c'est bon, décolleur. Calmez. Okay, now I'm going to join now the inferior part of the flap. There we go. Okay, so that's good for the inferior part of the flap. So this is the residual tympanic membrane, which I'll still use, and this is the skin. Okay. All right. So now, la tête en déclic, s'il vous plaît. Can you put la tête en déclic, s'il vous plaît? So I'm going to move my head a little bit down. Stop, because what I need to do now is to elevate the superior part of the flap. Décolleur, s'il vous plaît. Ok, calmez. Okay, so it's very important to reposition the flap step by step. And we have the ossicular chain, but I think there is a problem with the chain also. It's kind of a hypermobility of the malleus. So there is dislocation, I think, of the incus, or at least of the joint between malleus and incus. Alors, lancez le coudé. Ciseaux. It's quite a thick skin here. Ok. J'en avais d'autres. Calmez. Ok. Essuie. Yes, I will certainly have to do an ossiculoplasty here. Because there's a partially eroded malleus too, I think. It looks like it's pretty short. But stapes seems to be fine. Not sure, because I cannot see it, but it seems to be mobile. You see how this malleus is completely loose. Ciseaux. All right, there we go. Okay, so I think now I can remove the whole flap. So I need to place the Silastic sheet in the middle because I really need to find the cleavage back. Donnez-moi la lame de Silastic. Okay, so I put, as usual, this on saline solution. And now we'll need to check the ossicular chain. Respiration. Tableau vers moi, s'il vous plaît. Stop. L'aspiration, s'il vous plaît. Ok. Merci. All right. Calmez. Yeah, I have to remove the incus. You can see it's completely loose here, and do an ossiculoplasty with a TORP. I will try to use the residual malleus, which is partially eroded but still there. Curette. Okay, so let's do now the bony rim resection in order to have access to the facial nerve. This was probably interposed by the previous surgeon. Some kind of bone here. Crochet, s'il vous plaît. Curette encore. You see the cord tympani, which I try to preserve if I can. Okay, there we go. All right, désarticulation, s'il vous plaît. So I will now separate the incus from the stapes, and then I will remove the incus. Préparez une prothèse totale, hein, s'il vous plaît. This stapes is mobile.
C'est écrit avec le prothèse, c'est 614.
Okay. Crochets. So I will remove the incus now. And preserve both stapes and malleus. Passe, s'il vous plaît. Correct. Not easy to remove this incus. So sometimes if it's like this, I can leave it in the attic anyway. It's not a problem for me. I try to see if I can remove it. Crochet. If not, I will push it in the attic. There we go. Okay, it's done. Ciseaux, s'il vous plaît. Okay. All right. So what I will do now, I will relocate the malleus posteriorly. Lancez-le direct. I will cut the tympanomeatal tendon. Okay, les ciseaux à droite, s'il vous plaît. Débouchez. You can see how loose is the malleus. Okay, now I can relocate the malleus. Trying to use it. It's not going to be very easy. But anyway, I can place the prosthesis right underneath the tympanic membrane also. And underneath the graft. But I always try to use, even when I have some residual malleus, I try to always use it. This helps to stabilize a little bit the prosthesis. Okay, so let me now measure the distance. D'abord les ciseaux, s'il vous plaît. Okay, and I will cut the tendon, of course. There we go. Okay, mesureur. It's probably quite a long prosthesis to deal with this lateralized tympanic membrane, although I try to resolve the problem with the new graft. Yeah, it's 5, 6, 7, so it's going to be a 7. I think it's going to be a 7 long prosthesis. Okay. So I think the next step now would be to place the graft, but maybe I will place the prosthesis first. I need to check. Aspiration, s'il vous plaît. Yeah, I try to place the prosthesis first. Allez, la prothèse, s'il vous plaît. As usual, I use this Ossiculoplasty titanium alto TORP prosthesis with Silastic band. So I'm going to cut it. I want 7, so I will cut it at 6. Okay. And then pull it back at 7. Go. Okay, so that's fine. I will push a little bit lower the Silastic band because I think it's too high. go. Okay, I think it's fine now. It's good position. All right, so I think we'll be okay. I will introduce the prosthesis. First step is to place the distal tip of the shaft to the foot plate. Like this. And then I need to attach the prosthesis to the stapes with the bend. But we've got this quarter tympani right in the middle of the field. So I think I have to do it in a different way. Ah, ça inspire pas. Because you see, if I leave it like this, I will not be able to pass the quarter tympani on the other side. So this is the way to do it. On the other side of the quarter tympani, and I will now attach the prosthesis to the stapes, placing the shaft like this. Okay. Alors, crochet à os, s'il vous plaît. Calmez. See if I can place it underneath the malleus. Okay, this will help. I'm sure this will help. Okay. And now we'll attach the prosthesis to the stapes with the band. 3 de chouk. So this will dislocate temporarily the prosthesis from the stapes. So it needs to go underneath the tendon. But we have some residual tissue here, right underneath the tendon. Okay, this is better, I think. Okay, this is good now. Okay, now we have a nice vertical position of this prosthesis, held by the Silastic band, and then also stabilized a little bit by the malleus. Can we? Okay, I think it looks fine. If I move the prosthesis, you can see the stapes is moving very nicely. There's no problem with that. They're moving together. Okay. All right. Of course, now the next step, the final step, is to reposition the flap. But first, I will put my graft over it. Table level. So I remember that we have some skin stuff, missing skin on the right. So we'll have to also cover the bone here. All right, okay. So I need now to prepare and trim my graft using both sides, as I said, of the perichondrium of the tragus. So this is the lateral side, lateral side of the graft of the tragus. So we'll do 2 incisions like this. I know that I have enough skin here anteriorly. This is not a problem anteriorly, but I'm missing skin inferiorly, I think. Ok, vous pouvez mettre de l'eau, s'il vous plaît, pour l'humidifier. All right, so now we'll grab it and place it. l'enseignement du marteau. Big trick to place it correctly. Quite a trick. Of course, maybe we have a dislocation of a prosthesis, but this is not a problem. I'll rearrange everything at the end. What I want to do here is to cover, you can see this is of course dislocated, but I will come back to this prosthesis later. C'est un peu dur encore. Il faudrait l'humidifier encore un peu si vous voulez. Allez-y, envoyez dedans. It's too dry, so I need to... Non, c'est bon, ça va. Because I have trouble, you see, to stretch it. Okay, I will take my time to stretch the graft correctly all around. Because of course this will be of major importance for the risk of the lateralization again. I need to rebuild, I would say rebuild the anterior angle correctly. Large graft, you see how large it is, so it's good. So I'm covering at least more than the anterior part of the field, including the skin here. Okay. Cannelé. Okay. I prefer to have it more perpendicular to the parallel to the stapes like this, so it's vertical way. And now I will place the graft over it, but first, of course, I need to place the second part of the graft underneath. Okay, let's take the second one. This is the medial side, which is always thinner than the anterior one. Okay, I think a graft is fine, but I need to reposition, of course, the prosthesis, which is, again, of course, partially dislocated, but this is normal. This is better. And now I can reposition the graft. Okay, of course, the last step now will be to reposition the whole flap. Looks good. You can see how nice it is. Typically vertical, so it's fine. Okay. All right, now the last, but it's going to be tricky because, of course, this is a very strange flap that we have. So it's not going to be easy to reposition it because we have partially residual tympanic membrane, which might be a problem, plus the skin. But usually when I do this technique, we have a nice connection between the skin and the tympanic membrane, which is not the case here. Okay, try to replace now the anterior annulus and see what we have now. So you remember that I put a Silastic sheet in the middle, but it's just difficult to find the cleavage plane. It's like a puzzle, but with time we find a way. So this is the superior annulus. I remember the position. And of course, it takes time to reposition the graft to be sure that I'm closing the whole perforation here. Kennedy, okay. Scissors, s'il vous plaît. I think I need to cut the skin here to be able to replace it correctly. This will help. We have several parts of the flap separately, not a problem. All we need is to be sure that we are covering the whole bony canal wall, not leaving any bone without anything on it, any connective tissue on it. But this is good. Now we are controlling everything, I think. And the graft looks fine everywhere. And of course this part is quite thick. You can see here the residual tympanic membrane and the graft underneath. So it took me some time to know exactly how to reposition the flap, but now I think it's good. And I hope it's going to work. The problem is the thickness of this skin here. But anyway, looks good. And now of course I need to check again you can see how thick it is here. So I need to check the prosthesis. Yeah, again, dislocated partially, but not completely, so I need to reposition it. I always want a vertical position. Now it's fine. I'm happy about that. Ciseaux, s'il vous plaît. Okay, it's nearly done. Cannelé. Of course, we're gonna, feel the anterior angle and the whole canal with jet foam. Okay, that's fine. So let's put now the Silastic sheets. Cannelé d'abord encore, s'il vous plaît. I just want to be sure that all bone is covered by skin or connective tissue. Yeah, looks good. Okay. All right. Place it once like this to try to hold the anterior angle. All right, and 2 others all around the ear canal. Okay. Okay, so let's now feel the anterior angle. Okay. Of course, this will be very, very important to try to decrease the risk of recurrence of lateralization. There is always a risk, of course, especially in those cases where we know by experience when there was a previous lateralization, that means that the skin is pretty poor, and then there's a risk again of lateralization. The other option would be to do a skin grafting technique, but it's more, for the patient it's different. So I like this technique too, which is one we can do, and if it doesn't work, then we go for skin grafting technique. There's also a risk of stenosis of the canal. This is why I think this technique is very, very important. We don't have we had a large canal, but you can see the bone, the skin is pretty thick. Then decreasing also the size, the diameter of the canal. Okay, bon, je crois qu'on peut pas faire plus. Okay, that's enough. And I'm going to put a mirror cell. Removing it on the 5th day. quite easy. Okay, it was a tricky case, interesting way of dealing with the lateralized tympanomeatal. It could be controversial, of course, I understand, but always interesting to show what I'm doing, and this could be open some discussion about the different techniques. So thanks very much for watching, and see you again soon. Bye-bye.